Great. Welcome back to Super Doc Stories. I'm your host, Dr. Marissa Caudill, and it's my pleasure today to have Dr. Alok Pandya speaking with us. He's a pulmonary critical care specialist who has started his own business, finding a niche that many of us may not have thought about. But tell us the story, Alok. Tell us how you got into the business that you're in.
Sure. So, as a physician, I think we've all seen this shift towards physicians going and becoming employed. You see a lot, and especially in young residents and in the new fellows that are graduating, that they're going to work as an employee rather than in private practice. And I've always had a streak where I have a little bit of an entrepreneurial spirit. I just didn't know how to kind of deploy it. And I just would rather be my own boss than being told what to do. And so when I graduated, I joined a private practice, and unfortunately it closed. A private equity company had purchased the hospital, and I guess they exited after about 7 years, and they sold the land underneath it and leased it back, which for a hospital that had been there for more than 120 years, it really created a desert for healthcare in that area. So I had to scramble and find another job, and I found another private practice job, but it just was not the right fit. And sort of coincidentally, I was doing a favor for one of the primary care physicians that would refer a lot of patients to us. And I started rounding at one of the nursing facilities. And I saw that, there's a huge unmet need. There's at least 1.2 million Americans in nursing facilities, and there's more individuals turning 65 than 25 over the last several years. So this is like a growing area. And so if there's already a bottleneck of physicians, there's already areas where there is not enough providers available. This is one of them. And essentially it's like a captive audience. They don't have the ability to go out on their own a lot of the time. And there are a lot of obstacles in their way for them to receive any kind of care, but particularly subspecialty care. And so I realized that, this may be a big change in sort of the level of acuity that I'm used to. I trained at a center where the 2 years when I was a second and a third year fellow, we were doing 200 lung transplants a year.
Wow.
We were doing ECMO, VVVA ECMO. We were doing advanced bronchoscopic procedures. Even in private practice, I got trained on robotic bronchoscopy, and I realized that, I'm going to be leaving a lot of this, almost all of it behind. But what am I going to gain out of it? One is the sense of autonomy that I knew I was losing, even in private practice, which I can't imagine what it's like if you were an employed physician and that's what you've experienced your whole life, where you feel like you're like a cog in the machine and you're not really feeling heard. And the other is a work-life balance, which, I think gets thrown around a lot, but it was incredibly poignant because there's one particular experience that really stuck out was, when I was in my second job, I was traveling almost 45, 50 minutes back and forth. And with traffic, it would turn into almost like a 2-hour commute. So I'd leave at 6 in the morning. I'd come back at around 6:30. And so I was putting my daughter to bed, and she was about 5 at the time, 5 or 6. And she's like, "Daddy, I only really spend an hour with you every day. And I miss you. All right, good night." And I was like, wow, it's a real knife in the chest.
Jeez.
But I said, there's periods of time where, God is speaking to you. And, I really felt strongly that, my child was, maybe someone was speaking through her. And you will never regret spending too much time with your kids. Or spending too much time with your family.
You will in the moment, but at your deathbed, you won't. Let's correct that statement. Yeah. There definitely be moments you regret.
There's definitely times where I see too much of them, but I don't think I would ever regret.
But overall, it's a good spend.
Yeah. Overall, and so I said, you know what, I need to make a change. And so I started doing research into who actually goes to nursing facilities, and it's not that many. It's a growing population. There's money there. This is Medicare and Medicaid. These are large, well-funded insurers. Commercial insurers pay for this as well. With nursing homes, it's Medicaid only, but with rehab, it's pretty much all payers. So I said, if I do this instead, I'm going to have a lot more flexibility of time. So instead of being, 6 a.m. until 6:30 p.m. on a good day, I'm, more 9 a.m. until 4 p.m. and I have my
Hmm.
notes all done. So I'm not doing pajama time, doing, documentation at home. I have I can outsource my chart prep, my billing and coding, HIPAA compliance, my MIPS measures. I don't have to be responsible for it. I have someone else that helps me do all of these things. So, I started creating a network. You meet with a healthcare lawyer, you get a CPA, and you find that what you thought was a very onerous task of starting your own business is actually very easy. This country was really made almost for that purpose.
Hmm.
You realize how disincentivized you are by being a W-2 employee. You don't really have a lot of write-offs. Your
Yeah.
money is taken right off the top.
Hmm.
You have no control over that. And so what you're really doing is just, saving into, more of your tax incentivized retirement accounts and socking away as much money as you can. But that's really all you can do. For me, I saw that, you know, if I have this kind of ownership and I have this flexibility, you can scale it, you can bring other people into it, and also it's a lot more tax efficient.
Definitely.
So
Can I interrupt and
a little bit
ask,
more.
like, with all of those things, right? With a healthcare attorney, with someone prepping your notes, with someone doing the billing for you, does your overhead come anywhere close to what a private practice overhead typically is, like 30, 40%?
No, no. I would say, in where I was, the payer mix wasn't great, and everything else was very expensive. So payroll kept going up, and the utilities kept going up, and the rent kept going up, and things needed to be renovated. So when I was going through the numbers with the old at the old firm, it was like at least 50% was the overhead.
Yeah.
They're pretty
Hmm.
high. So, if you think about it just realistically, you see 20 people, 10 of that is just to pay your overhead. And now you're really trying to scrounge, through this environment where there's a lot of peer to peers, denials, second appeals. And you're lucky to be recouping, whatever is your fee schedule, maybe 30% of it, 33% of it. And so what I found was that my overhead became closer to 10%.
That's amazing.
So, I can't necessarily say to Medicare, please pay me more. You could if you're, a large enough group and you can have a negotiation with payers about what your fee schedule is like. But as like a solo practitioner, that wasn't going to happen. I was essentially going to get whatever the Medicare fee schedule is going to allow. So the only thing I really had control over was either seeing more people and or just reducing my overhead. And so I saw that I could probably see the same amount, maybe slightly more than I was seeing before. And even with the reduction in what like a skilled nursing or a long-term care encounter would pay compared to a hospital visit or an outpatient clinic visit, I was still making a lot more because my overhead was just so much lower. So when I was running the numbers, I saw that, look, conservatively, if I saw this many people and I got, at least, 30% of what I was asking for, I would be able to make the same amount that I was in private practice. And since then, it's easily doubled. And that's just me working by myself with like one part-time nurse practitioner. The real strength of it was just, the flexibility with my time and just the strength and reducing overhead. That was like the magic sauce. And then on top of that, just being in a more tax efficient,
Hmm.
LLC. I just had a lot more things that I could write off my gas, home
Hmm.
office expense and things like that.
Amazing. Well, I bet there's a lot of people listening right now whose wheels might be starting to turn because, like you said, we know the aging of America is real. So the number of people who are living in skilled nursing facilities or acute rehab places is going up everywhere across the country. And many, if not most, medical specialties could, with a little creativity, imagine a role for themselves in those facilities, I think, as specialists, like you were saying. And you were
Absolutely.
describing earlier something that I hadn't thought about, which is they're kind of a captive audience. Like you can just go from 9 a.m. to 4 p.m., see all the people there who need your services, and then go to the next facility. So tell me a little bit about your day. Like, do you go to multiple facilities every day? How often do you go to each facility?
Sure.
Are you on call if something, urgent is happening to try to prevent an emergency room visit for a patient? Like, how does that all work?
Sure. So I go to multiple facilities a day. I average about three, but I group it geographically. So if there are three in a cluster, maybe just a few minutes apart, that's what I'll do. I'll stack it that way. I will go to a facility every week as long as there's a consult volume that would justify it. I have good communication with the director of nursing, the assistant director of nursing, nursing home administrators, and the PCPs. And they'll send me through text or email, hey, could you see this person and that? And what I'll do is I'll send it to, I have a team in India that will then create the chart using, I use eClinicalWorks because it's a cloud-based EMR. So I just take my laptop everywhere I go. And they'll create the chart usually within an hour or so. And then I'll go and I've already done my chart prep. So if it's follow-ups, I've known them very well. And if it's new patients, I've gone through their discharge instructions and summaries from the hospitalization because I'll have Epic CareLink access to all of the local hospital systems. And so I'll be able to look through their CT scans, their other imaging, echoes, and then I'll go and see them. And usually I'm rounding and I'll just dictate into my phone, just some notes after I've seen them, or with like a pen and, paper. And then I'll go back to my little hovel and I'll do my documentation and then I'll just go. And the team in India will upload the notes to Point Click Care, which is the pretty standard EMR that's used by most nursing facilities, and then send a follow-up email saying, hey, these are the people that I saw, and we could just go over my recommendations or the orders I've already put in. And so I'll kind of go through that. So usually start around like 9:30, and then I'll be done by around 3:30 and I'll be back home. And so, I'll have time to be able to either get the kids ready in the morning if I need to, or pick them up from school. And then, dinner and bedtime. That's pretty much
Beautiful. So, but this was a shift for you, and I'm curious, like emotionally and with your identity, because you trained in, like when you said 200 transplants a year, that's crazy. When I was training at UCLA, again, I'm a psychiatrist, right? So I had to do some internal medicine, and UCLA is a tertiary care center. One of my patients on that rotations was the oldest heart-lung transplant recipient ever. And so I still remember being like, I have no idea what I'm doing, but I'm pretty sure I should not be this guy's doctor. Like, it's very acute, right? Like when someone's getting a heart lung transplant, ECMO, like that stuff that's intense. Like that's life and death stuff. So now you're taking care of, I'm guessing, people with pretty chronic conditions. We have a visitor. in Oh, she's lovely. We have, people in skilled nursing facilities probably are there for months, if not years, in many cases, right? So these are people you really get to know. They're not so acute, not so much as changing on the day to day. There's good and bad about that, I would guess, right? In terms of feeling like you're still flexing your,
Exactly.
muscles and what you know how to do versus just caring for people, which is what we all went into medicine to do. So how was that for you? Because I'm guessing there was obviously it's worked out financially okay and lifestyle wise okay, but is there any part of you that feels like you're less of a physician or less of a doctor? Like, did you have to process through that as you were going through this
That's a really good question. And it was probably the first, you have like a sense of like imposter syndrome whenever you've made these transitions into med school and residency and fellowship. And then, as like a first year attending. For this, it was about 6 months or so. I was like, what sort of value am I adding? I did all this training and now I'm giving it up. Was it worth it? Did I do a disservice to the patients that I had before? I'm like, look, me being in the ICU or doing procedures provided service and a value to the health system, but it wasn't going to change everything 180 degrees. I need to take my own ego out of the equation, that not everything revolved around me. I was not like this like focal point, this cornerstone of it. like when we were in residency or fellowship, we're like, what happens if I'm sick? What's going to happen? If someone can't cover me?
Yeah.
It's like the world will go on. Like the attending will see these people. Um, and so I was like, okay, if I'm not there doing this, what am I doing? And again, it was pretty pretty apparent immediately that just another set of eyes on these patients, just doing a medication reconciliation, making sure the discharge summary, everything that they were supposed to be on is what they're on. Are they not on duplicate therapies? Why are they on these antibiotics? Why is there no end date on this medication? Has anyone, talked to anyone about this incidental finding? Sometimes it's completely unrelated to pulmonary. And I was
Mm-hmm.
like, yes, there's definitely a need for it.
Definitely.
Is
Yeah.
it, is it the acuity I'm used to? It's like, no. But I also realized that, when I was in fellowship, my thought was very skewed as to what the population is like, because I thought everyone is end stage COPD and fibrotic lung disease, and everyone is going to get a transplant. And everyone has this like, it's not like that. That's not what the world is like. Most of what you're going to see is going to be like unexplained dyspnea, like a chronic cough. That's what I saw in private practice, and here it's a lot about being almost like a primary care pulmonologist. No one's weaning this oxygen. They've been on oxygen for 6 years. I'm like, well, let's just turn it off. Let's see what happens. And it's like, oh, it was like a pneumonia from like a decade ago, and they just kept them
Wow.
on it. This CPAP they've never worn, and they have a lot of daytime sleepiness. It's like, why? Because no one actually, they have this like cognitive impairment, and they don't know how to put it on by themselves. Like, hey, maybe we should let nursing know and maybe we do an in-service so that people understand how to use it. You know, we're used to a certain level of acumen in nursing and in our providers, training at academic centers. But we realize that it starts to disperse and starts to get diluted the further out you are from
Mm-hmm.
training and from an academic center, because no one else is really watching over your shoulder. So if you're in an area where no one is really watching over your shoulder outside of yourself or other people in your group, then who's going to hold you accountable? And so that's one of the things that I saw very apparently within the first 6 to 12 months was like just being there and seeing these people on a regular basis. And even if the problem set that you're being asked to see is only a couple of things, you're still providing a lot of value.
Yeah.
Because then they'll tell you things that, maybe they forgot, or it just wasn't brought up the last time they saw a physician. So I did have that imposter syndrome, and I still feel like, yes, I do miss out on those things, but missing out on doing those advanced procedures compared to what I got by giving them up by doing this different model, I'm like, no, I would do it. It's like hands down, I would do it again 10 times over.
I love your perspective. So I think in both ways, the perspective where you were talking about your daughter was the one behind you, the one who told you, like,
Yes.
I never see
Yeah.
you, Dad, but that's life.
Yeah.
So I think you're absolutely right. Like, I think, and the different doctors I've talked to on this podcast have different moments like that, right? But we all kind of have some moment that's a wake up call where we're like, what am I doing? And there's that ego, right? Because we were doing it because we thought good doctors do critical care or good doctors do this level of care, whatever it is. But really, that's just a story we've been telling ourselves. And the reality is, we will be a good doctor wherever we bring ourselves. And I think the other thing that you talked about that was so valuable for people who might be listening is we know so much. Like, you had this just from your exposure, from your experience. As you said, you did this back of the napkin calculation after talking to someone who was doing skilled nursing care visits and realized, like, this seems like a no-brainer, right? Like, we know the patients are there. We know there's no one serving them. Like, could I do this? I guess I could. And then when you were describing going to that first facility and offering yourself on this silver platter of like, I could do all of this for you, they were probably so excited. They probably were thinking like, where did this wonderful human come from? Like, how do I deserve this? Because they would be dreaming of that, right? To have someone who's actually like thoughtful and caring and like wants to come in and take good care of their patients. in exchange to bill Medicare with no added cost to them and reducing their stress about caring for their patients? Like, which facility wouldn't want that? I'm curious, have you ever had a facility say no?
No, actually,
Yeah.
I've said no to certain facilities because so there's still like for some reason a fair amount of like territorial nature to some of these physicians when they've been at a facility for a while. They don't want someone else to intrude. They don't want too many cooks in the kitchen, I guess would be maybe
Yeah.
the analogy to use. Um, but no one's ever said no for pretty much the same reasons that you elucidated, which is that if you're not going to cost anything and you're not like a con artist and you have good training, you're a good person, and you know a lot, and you just want to provide excellent care, and that's what you're used to, then why wouldn't you want to have people like that in your facility? And so, yeah, as I remember, I was having a meeting with one of the clinical liaisons and one of the nursing home administrators, and one of the executives. Most of these places, they're owned by like larger corporations. And I just said, this is what I do, and this is who I am. And they said, okay, so we're going to start you at all 5 of these places in Philadelphia in 2 weeks. And I was like, okay, that's great. Maybe we'll space it out a little bit. But there's a huge need for it. And it's not this corporate greed need, which, obviously it helps their bottom line if you're reducing readmissions, decreasing their healthcare burden, at least from a provider standpoint, maybe helping them find cheaper therapeutic alternatives for their, inhalers, doing in-services and things like that. But they also understand that, physicians are a very rare commodity in this space. And so if they can find one, they're not going to let go. And the good thing is that then they're your advocates as well. Sometimes, in a hospital setting, you may be at loggerheads with administration. Here, everyone is aligned. Patient care, the nursing home bottom line, where they have very thin margins, and being a practicing physician and your flexibility in your time and your compensation, everything is in line. And so it's actually been very harmonious. I've actually had very, very good relationships with all of the nursing home staff, and the patients have been they're very kind and they're very appreciative. They understand when constantly they were saying, like, before, if I went to like a doctor's visit, they're looking at the clock, they're looking at the computer screen. It's like it's refreshing that you can just make eye contact.
Mm-hmm.
And what's going on, and you're building a relationship. So that's been incredibly rewarding. I didn't think that outpatient medicine was going to be that rewarding, because I got into pulmonary critical care because of the ICU and the procedures, and the outpatient part was only as a way of feeding into
Right.
the procedures and really looking at the acuity. But even this lower level of acuity, larger volume outpatient has been very rewarding. So I found a way to change my mentality about what brings me joy in medicine. What brings me joy in medicine is not procedures and acuity, it's about taking care of people. And so when I had that mind shift change, which happened 6 to 12 months after I started the business, I found a lot more joy into it. And I didn't
That's great.
second guess myself for doing it. Maybe I needed to do it as a way of comforting myself, so I didn't always feel on edge about being a fraud or position. But I felt like there was enough feedback from the people that I was serving, the patients, that I was like, okay, this is very real. This is not something that I'm just telling myself. This is, absolutely something that's necessary.
I can only imagine that the patients you serve just view you as like heaven sent, because I imagine living in a nursing facility for weeks or months or years would feel very isolating. So to have someone kind and caring who comes and talks to you is probably the highlight of their day many times.
It
Um,
is. It is. Unfortunately, skilled nursing is one thing. Get a hip replacement, knee replacement. You're going to be there for maybe a couple weeks or so, and then you go back home, back to your same level of independence. So rehab is one thing, but long-term care, what really pays for it, unless you're independently wealthy or you have personal care insurance is that long-term care insurance is that it's going to be Medicaid.
Yeah.
And in order to qualify for Medicaid, unless you've thought long time ahead and you've already dispersed your assets to your children and your grandchildren, you have to liquidate everything.
Right.
You have to spend down all of your assets, and that goes away really quickly. One patient encounter was this lady I see at one of the nursing facilities. She's long-term care. She's like, I was a teacher for like 40 years, and I had a pension, and I had my savings, and $400,000 was gone within 4 years.
Yeah.
And so now, they're at a facility. They don't really have the resources to go and live independently, or maybe just they have so many comorbid conditions and functional limitations that they can't. And so, yeah, they're very isolated, and it can get very boring. And there's also different sort of levels. We see Medicare star ratings when you're looking for, hey, grandma should go to a rehab, but when we go to a 5-star facility that's close by, it's like, well, some people don't have that option because the 5-star one has already been filled with good payers, and they have only so many beds. And so the people who may not have like the best paying insurers may have to go to other ones like 1 or 2-star. But these are still people. These are the patients that you've been following your entire life. And so they do get bored. My heart goes out to them because at the end of the month, they only have so much that they can spend. So, on top of this, I just seeing them and building a relationship, I was like, you know what? I went to one place today, and a couple of weeks back, I was like, why do you have all these bags of clothes? Like, well, sometimes people come in and they get dumped by their family, or they're homeless and they're a placement issue, or, they're waiting for laundry to be done. It takes 3 days for the laundry to come back. They don't have any clothes while they're waiting. I was like, let me just do a clothing drive. Let me just get it all. My neighbors to donate. So I have like 10 bags of clothes. Like let's just make them have like a thrift shop.
Yeah.
They get like dollars, and they can go shopping. Gain back some of their their sense of autonomy, their sense of joy.
That's beautiful.
So it's part of activities, part of like their occupational therapy. Is like it tied it all in into it.
So you're really becoming part of these communities too, and helping them, not just with what you're asked to do, but really thinking, how can I make life here better for everyone?
It's what you would have done as like a resident or a fellow. Like I remember, when I was my 1-year OB residency, there was like a young kid coming in with their grandma. She's pregnant, and now it's like 2:00 in the morning. They're in OB triage. Like, how do I get home? They don't have Uber, they don't have Lyft. I was like, I'm just going to give you $20. Like, you would do it. Like, you would just do it because you're a good person. You're a physician. You care about your patients. So rather than, you're going there, you're not trying to be extractive. You're not going there and just, let me get the consult list. Let me just see people as quickly as possible, like putting a mirror under their nose, seeing if they fog it, and leave. You're part of their community. This is their home. And if you're going to go into their home, you're going to treat them with respect and dignity. And that's something that they lose sometimes when they are out of their house and their family is far away. And so, you want to be a good steward for them. And so if I don't have to be looking at the clock and I don't have to be watching what the waiting room looks like, how am I going to use the time that I would have spent doing those things? I don't want to spend it just wasting it by like doom scrolling on social media or something like that. I'm going to do it by giving back to, the administrators that are working really hard and maybe somewhat thankless jobs, and to the patients that are there, the residents that are there.
You're really, well, first of all, I think you're not giving yourself nearly enough credit because you're clearly a very caring person. And I don't think everyone would function the same way you are in your role. But you're also painting a picture of kind of what I imagined medicine to be when I wanted to become a doctor. So I had a family practice in Maine that was my home, my medical home, and they took care of my grandparents and my parents and me and my sister. So they knew the whole family. And I never did feel like they were rushing us to see the next patient or stressed. It was a very laid back, relaxed kind of pace. And so to some extent, what you're describing is the same in that you aren't bound by, I have 15-minute appointments and I got to keep going. And now I'm behind in my schedule. So I'm going to be stressed because my support staff is stressed and there aren't enough rooms and the people are getting agitated in the waiting room. all of that isn't part of this equation for the care that you're delivering now, right? Like you aren't
Yeah.
on anyone's schedule. You're just there to meet them where they're at a time that works for you, and they're there anyway, so it's going to work for them. It's kind of ideal, really.
It is like if I go into like the memory unit, with people who have advanced dementia, you know, they may not be able to give me a lot of history. You see them, and those appointments will, that slot will be a little bit shorter. But you have that flexibility that the person who's you're trying to nail down, your chronic cough, or what's been going on, or maybe they're just a little tangential and they're going to talk about something else. Like, look, I got time.
Mm-hmm.
They will. Everyone will perceive that the physician looks annoyed or that they look rushed.
Yeah.
You don't have that perception. If you're going to see them on your time, and you're giving them your time, then they have all the right in the world to use up that time. And so, you know, then I don't feel bad. If they're going to tell me this long-winded story that somehow involves, like, the third grade English teacher and whatnot, it's like, that's all right.
Right.
Maybe I just need you to talk to someone, and that's therapeutic as well. Fine. If this gives them some catharsis, then that's not a problem. Sometimes I do need to cut them off and say, look, I do have to go see some other people. But you're right. That was one of the things. Like, before, you had to worry about, oh, I got to make this, peer-to-peer call about, someone who's already left for rehab that they're not going
Right.
to, reimburse for, or, filling out these prior authorization forms, or, hey, you better eat your, lunch in 10 minutes because, I know you said at 1 o'clock, but this is a 12:30 urgent visit. So we're going to book, room them early. If you're not dealing with it, then you need to, be able to delegate that time towards your patients. And so that's been probably one of the most rewarding things, is that I don't have that sense of burnout. I don't have that sense of sort of clock fatigue, just constantly staring at the clock and doing the arithmetic of, okay, I can only have them babble about this for 5 more minutes because I'm already 20 minutes behind and I need to get this person in. So it also gives me the opportunity to say, look, I can't imagine. I never did, when I was a resident or a fellow or an attending, getting an email through Epic of, hey, I saw I saw Mr. Smith in rehab. We just did a med rec, and we worked on his inhaler technique, and actually he's probably better on nebulizer therapy because his BMI is 16, and he doesn't have the inspiratory effort to be able to use these dry powder inhalers. You're like, oh, I just assumed it was a black box. I get no information out of it when they go to these facilities because nothing interacts with their medical record system. They come with like a triplicate carbon copy form that I scribble something in, and then it goes back into the ether. That's what it was like.
Mm-hmm.
I was like, wow, you can serve as a bit of like a transitions care person. You can be that liaison and say, look,
Yeah.
This incidental finding. Oh, hey, he had a history of a lung nodule from 5 years ago. He hasn't followed up about it. Hey, let me reach out to his, medical oncologist, his pulmonologist, and say, hey, can we get him seen? Get another CT scan. And it's exactly what happened last week. This patient was being followed. He had two upper lobe nodules that had been irradiated, and he was supposed to follow up. He never did. And then incidentally, he went, had a fall. They did a CT scan. They saw that he had some new nodules. But that was 6 months ago. And then I saw him for the first time, and I said, oh, we should probably follow up on this. So it's also finding things that, just due to the volume of patients and the paperwork, one provider is sometimes just not enough to be able to handle all of this, because some of these primary care physicians are they're all rounding at multiple facilities, or have an outpatient clinic, or they're rounding in the hospital. So it's easy for things to fall through the cracks. And so I feel like I'm able to kind of provide a little bit of a backstop for at least some of the pulmonary issues.
And it's so important, those transition of care moments from inpatient to rehab, from rehab to home, from home back. Like, all of those are points, as we know, where things do tend to get lost in the handoff because the well-meaning, well-intentioned team that's caring for them in one place tries their best to summarize and then hands it off. And it's not always clear who's going to be researching and reading those
Yeah.
treatment plans. So it's great that you can fill those gaps and catch those things for the patients that you're serving. I wanted to ask, so when you started this, you were clearly leaving like a steady paycheck. You did the back of the napkin math, figured like, okay, it should be okay. Did you go 100% in on this new venture, or did you do some part-time locums work, or did you do
That
1099
was
work? Like, how did that transition happen?
I just went all in.
Nice.
So one thing about my wife and I is that we've always just had a mentality of just like save and put it away. Pay down any debt and save, as much as possible. So we always had like an emergency fund, but we never really thought of it as an emergency fund. It was like, this is never going to happen, but we should always have something here anyways. But when I started doing the calculations, I was like, look, it's going to take about 3 months, one for credentialing, even after seeing these people, making sure the credentialing goes through, and for the payments to go through. It's going to take time. Medicare, if your claim is completely devoid of any errors and it gets accepted, they pay the quickest, about 15 days. But other payers, it could take 30 days, it could take 60 days, depending upon if there's denials and appeals and all of that. So I said, look, this is how much we have right now. I'm going to do this at this time, and this is when I anticipate the first paycheck coming in. So my wife is not happy about that part of it, which is that there's no paycheck. When's the paycheck going to come? And I said, you got to trust me. We're gonna do fine. So she's like, you need to get like a locums job. You need to like work part time as a hospitalist. I was like, I haven't been a hospitalist for a very long time, since I was a chief. So to do that and then do it for like a little while, it doesn't make a lot of sense. And I want to devote all of my time and attention to it. So yeah, my math was surprisingly accurate. We got to very close to where we would have had to start dipping into savings. But I wasn't like inventing it wasn't something new. I'm not a very creative person. I was really just like templating what someone else had. I have enough people in my corner that have been doing this professionally, particularly in my family, has a billing and coding company, that I knew what the timeline would be like. And they were all in on it as well. And so I was like, look, I'm just going to believe in myself and trust myself. I'm not going to hedge. My mentality before as like a physician, and especially as like an internal medicine doctor, is like always hedge. You always like think about the worst case scenario. It's like, look, I can't think about the worst case scenario. I have to think about the most likely scenario. Like the probability of this failing is very low.
Right.
And I have to go by that mentality rather than the 5% chance that I was going to fail. It's like, I look back, it's like, what have I really failed on in my life? Yes, I've had setbacks, but I've always tried. And even if I failed a few times, I eventually persevered. And I was able to get to this point. And other people, just as smart, just may not have had the luck or the ability to do what I did. And so I was like, look, if I would, sell my blood, my plasma, or cut off my arm. Like my family is going to be well cared for. It's not going to happen. I would work at a car wash if I need to, but this is not going to fail. I know it's not going to fail, so I'm not going to have that mentality. And so, maybe it was a little bit more optimistic, but probably realistic compared to like, sort of like the doomsaying we would always think of, like in fellowship and in residency. So yeah, then I quit in November. First paycheck, the first check started hitting in first week of February. So there was a little bit of tension, but after that, it was like kind of guns a blazing. The ramp up of the number of facilities it just rocketed up, and then you start building your accounts receivable, and some of that starts trickling in, and you have the new business that comes in. And so even with essentially 2 months of like no income, I still ended up making the same amount that I did in my private practice job the year prior. And then once it was 2025, then it was a lot more.
And now
And
you're looking to hire people, right? Because you've got more business
yeah,
than you can handle yourself.
that's the biggest problem, is just like finding other people who are willing to take that leap. There's enough people who are willing to do part-time work, but my mentality, and I think it's somewhat selfish, is that I don't want these people to feel like they are part-time work. Like the residents and patients should not feel like they are a vestigial part of a clinic or someone else's day-to-day. Like this is something that we're going to dedicate time and attention to. And so I really like people who are full-time, but I'll kind of take what I can get right now. The nurse practitioner I have is amazing. She's been working at this vent facility for more than a decade, so she is, very, very good. But I feel like the work product that we put out there and our patient interactions is a reflection on our character, our character as people and as physicians. And so I don't like sloppy work. I don't like weak differential diagnoses. The same sort of thought process that I would have working in an ICU and in advanced pulmonary med surg wards. Like I take that. I don't use it all the time, but that mentality is something that you spent a lot of time, blood, sweat, and tears forming. And I talked to the interns at the residency program I was at. I was like, you're not a great doctor because of the procedures that you can do. It's your critical reasoning skills, your ability to stay away and recognize cognitive biases. That is the thing that makes you a good physician. Everything else is like icing on the cake. And so I continue to use that, and I have to hold myself accountable for it, and not be like, oh, I can just write this off. It's like, look, you have to keep digging. You have to be kind of like a bulldog about it. Why is this person the way that they are? Why does their CT look like this? So yeah, that's like the standard that I realized that I would never give up. And so I realized that even though the acuity has changed, I'm still a good physician, just in like a different role.
Yeah, I think that's a beautiful way to kind of frame that you're still the wonderful trained physician that you've always been with the high standards that you have. You've just decided to apply those high standards and this knowledge and these skills to a different population base. And it's worked out really well for you. So tell everybody about how they could reach you, where you are, so that if there's anyone listening saying, I want to work with Alok, like he sounds awesome, they can reach you. But also, are you welcoming of, could someone reach out to you? Are you willing to provide us your email and your contact information so we could include it in the show notes, so that if they're thinking about doing something like this, they could pick your brain and find out how you did this journey?
Absolutely. Okay, I think, any opportunity to allow physicians to gain autonomy and have an entrepreneurial spirit, like this is the thing that I'm doing. There's so many avenues where you could be an amazing physician that does not involve necessarily, not to denigrate anything else, but it does not involve you having to be a employed physician at a large academic facility working for the VA, or saying, look, I don't like any of this, I want to do concierge medicine. Like all of those things are fine for different people, but there is a lot of opportunity for you to provide care just in different avenues, whether it is just opening up your own private practice, or maybe contracting with a hospital and saying, look, I will help you run a hospital at home program. There's so many opportunities out there. But yeah, if anyone wants to talk to me about how to get into skilled nursing and nursing homes, how to do the market research, anything like that, I'd love to talk and, give you my time. So you can reach me at Dr. P, DRP at Spiromedics, SPIROMEDICS.com. I really have no social media presence. For me, I had no need to do it from a marketing standpoint. Maybe it would help in getting employees, but I found that I was wasting a lot of time on things that were not related to my family and my business through that, and it was all distractions. But if they reach out to me, I will not hesitate to set up a time, and you can talk my ear off about it. I love talking about it. I think if more people can get into it, then we can extend our expertise and the kindness and compassion that we learned in residency and fellowship to areas that just need it a little bit more.
I think that is just wonderful. So thank you so much for taking the time and being so generous with your knowledge and your experience. I think you're going to get some people reaching out to you. But I really appreciate you, Alok, talking to us about Spiromedics and your work with all these facilities. Thank you so much.
No, thank you so much, Marissa.